we have no other topics left. So if you wish to participate, for instance, well, discuss some ECGs or the way how should we analyze ECG, then please, well, text me. Tell me that you wish to do that, but in that case, it should be a dialogue, not a monologue. Good. Then, if there will be no more comments, please, well, check whether the link for Google Class form to check your attendance is working or not. If not, again, please text me or raise your hand. Meanwhile, we need to proceed to my slides and discuss some basic topics associated to systemic hypertension. Good. Well, there is a text message. It works. Fine, that's good. Well, talking about, yes, the syndrome of systemic hypertension, it's literally syndrome. It's not a disease. And in turn, it will include one disease that we'll call essential hypertension, and a set of syndromes that we need to discuss at the second part of today's lecture. And you will continue discussing them at the next years when you'll have faculty or hospital course of internal diseases. At that time, again, you'll discuss again secondary hypertensions, first of all, because there are quite a lot of them. Second, because those issues are quite complicated, so we just will start to discuss those issues, and there will be a lot of things to do in future. Meanwhile, we need to start with mostly all discussion of the primary hypertension first. Therefore, when we talk about epidemiology, definitely that these data will be related to syndrome in general, to just elevated blood pressure. But definitely most of those patients will have primary systemic hypertension. So again, if we talk about the population that will be quite intensively controlled and monitored in several studies, like that was represented here in report of Joint National Committee. In the United States, quite a lot of adult population will have quite high levels of blood pressure. That's regarded as at least moderate severity of hypertension. That is about 15 or 20% of adult population in American population. Second point is that we need to differentiate, and maybe a little bit later I'll try to show you why. Again, that's quite a complicated issue, and maybe we'll just start to discuss that. Hope later you'll continue. That we need to differentiate systolic from diastolic hypertension. Diastolic is somewhat more rare. Diastolic is much more complex in its pathogenesis, and in many cases less controllable from the point of view of efficacy of treatment. However, that the percentage will fall about 3 or 4 times if we talk about diastolic hypertension. So we use diastolic pressure of again of moderate hypertension, that is 105 millimeters per diagram. That will be about 5% of population. Another approach will be the approach of insurance companies, and you they'll consider hypertension as state with elevation of blood pressure more than 140 to 90 millimeters per diagram. In that case, there will be even high proportion of patients suffering of hypertension. In many cases, the data that we receive is based or related to so-called Framingham epidemiological study. Very well known. It was published quite a lot ago, I think, even earlier than 15 years ago, the initial recruitment of patients into the study. So now we have quite an intensive follow-up of patients. Sorry, just a second. Дало. Добрый день. У меня просто сейчас занятие в Zoom. Если коротко, да. Да, хорошо, ладно, я закончу сейчас, тогда перезвоню, да. Спасибо. Good. So a point is that we need to monitor our patients to assess the value of our data. We need to find out what will be the basic outcome. And for that, we need to decide what will happen to our patients in 10 and 15 and 20 years later after recruitment, to understand actually what was the role of risk factors, predisposing factors, efficacy of treatment, efficacy of monitoring of the patient. That's important. Unfortunately, well, for Europe, for Russia, the distribution of death related to systemic hypertension is not in favor of the European continent, because we have quite a high death rate associated to systemic hypertension, in contrast, for instance, to American continent, to African continent. And that may be even higher if we talk about Europe, Central Europe, first of all. What's the role of that? It's difficult to say just, there is no one single factor that will determine why there is so broad difference between, let's say, the lowest ratio here in the data of 4%, the highest rate that was recorded in that study is 10 times high, it's 40%. Definitely that there are different factors that may result in that. Maybe lifestyle, maybe dietary factors, and definitely that may be associated to genetics of the population. Well, from the point of view of pathophysiology of hypertension, we need to say that there are a lot of physiological mechanisms that will determine actually what blood pressure patient will have. The two straight components that will affect that will be the cardiac output, that will be related to stroke volume of the left ventricle multiplied to patient's heart rate. And definitely another important mechanism that sometimes may be independent mechanism will be peripheral resistance. So these three, the basic clinical and physiological components will determine the end result, the blood pressure. But point is, what will be the mediation of those final processes, and actually why, through which component, through which mechanisms, some central factors, the vasomotor center in medulla oblongata, will result in change in the tone of the peripheral blood vessels, and in contractility and rate of the heart contractions that will determine directly blood pressure in a patient. What is important, and actually this scheme is the scheme that will explain not just the blood pressure system regulation in general, but mostly why patient may develop primary or essential hypertension. Point is that there will be a very important bidirectional link between the pressure receptors in great arteries like bifurcation of carotid artery, carotid sinus, and aortic arc. The impulsation will go to medullary centers, and there may be some modulation of the sensitivity back from medullary centers to receptors in carotid or aorta. And therefore, in many cases, hypertension will not be related to some certain broken mechanism, like, for instance, severely elevated peripheral resistance, or some certain hormone level that will result in increase in stroke volume or severe tachycardia in a patient. It may be associated to decreased sensitivity of carotid and aortic pressure receptors. And in that case, patient may have absolutely normal level of functioning of blood vessels or the heart. There may be normal the regulatory mechanism, like functioning of kidneys, of adrenals, of uh, um, some other endocrine organs like thyroid gland. But point is that the decreased sensitivity of receptors will result in less intensive impulsation to central centers, to medullary centers in the case of normal blood pressure. And in turn, if blood pressure will be elevated, the pressure receptors will indicate that blood pressure is normal. And central nervous system, that the peripheral endocrine mostly organs, will maintain with most of the efficacy, will maintain not normal but elevated blood pressure. So what may go wrong to pressure receptors? Why there may be a significant increase in their threshold, and why they may perceive normal blood pressure as decreased and increased as normal? The explanation lies in atherosclerosis. Mostly it may be associated to other factors, but mostly it's associated to atherosclerosis, because if we talk about receptors, there are definitely different types of those, but in most of the cases, what lies in the wall of the blood vessel and indicate the level of the blood pressure definitely will not be the pressure sensor directly. It will be some kind of a spring like a spiral structure. And according to distension of that structure, central nervous system will perceive information about what's happening in blood arteries, in arteries or for greater circulation. Therefore, if artery will be overdistended and therefore the spleen will be too long, it will become too long, it will be perceived as elevated blood pressure, or either in the case if spleen will be compressed, that will be perceived as decreased level of blood pressure. But if artery will become too stiff due to atherosclerosis, if there will be atherosclerotic plaque, if it will be calcified or just for severe well, stiffness of the wall, that will be less distendable. In that case, elevation of blood pressure will not be followed by distension of the blood vessel, of the wall, or the pressure receptor. And that may be one of the explanations of the mechanisms how essential hypertension may develop. That will be associated to decreased sensitivity of pressure receptors, first due to atherosclerosis. What may be the other factors, we'll talk a little bit later, but again, most of them are associated to presence of atherosclerotic lesions. So if we talk about predisposing factors or modifying factors for systemic hypertension, you may find out that there will be mostly factors that will be related to presence of atherosclerosis. That will be the elderly age. Some racial factors will be most associated to some genetic predisposition, again, for atherosclerosis. Quite few of them will be directly related to hypertension itself, for instance, to sodium balance or the rate of activation of some hormones like steroid hormones. Male gender. Smoking is an independent factor, but smoking may be also realized through the damage of endothelium, and will predispose patient for more intensive absorption of cholesterol, and that may result in central atherosclerosis with decreased sensitivity of receptors. If patient will be overweight, if there will be glucose intolerance, or definitely there will be obvious diabetes, serum cholesterol directly, all those factors are factors associated to the rate of development of atherosclerosis. For smoking, the point is that smoking may be related to development of hypertension also without being mediated through atherosclerosis. The problem is that if patient will smoke, there will be shrinking of the arteries, and again, that will result in the situation that, in comparison to normal blood vessel, a contracted blood vessel due to the action of nicotine will result in a transient elevation of the blood pressure. If that will happen, let's say 20 times per day, if patient will smoke 20 times per day, that will result in 20 times per day elevated blood pressure. And again, that will be the way of training of the pressure receptors in central arteries. And in that case, as for instance, in the case of chronic stress, again associated to repetitive elevation of the blood pressure, that may result in development of impaired sensitivity of pressure receptors. Alcohol. It's difficult to say what will be the the obvious mechanism of the action of the alcohol, because the acute effect of alcohol may be ambiguous. In some patients, it may decrease level of blood pressure. In some, it may increase. Another point is that in severe alcoholic patients and patients that will take alcohol in riskful doses, there is a decreased level of atherosclerosis in comparison to non-drinking population. Therefore, it's difficult to say what is the action of alcohol. In some patients, it may decrease, in some, it may increase, or it may impair some other more sophisticated mechanisms, like, for instance, the metabolism of cholesterol, of lipids in the liver. That is the burden of disease that will be attributed to 20 gene factors. And again, most of those factors will be associated to the level of hypertension, and definitely at the top of that chart is hypertension itself. But most of the factors listed here will be the factors first associated to hypertension, second, directly or indirectly associated to presence of hypertension. Going down, that will be the smoking, either direct or indirect smoking. It may be passive smoking. It may be the diet that will be low in fruits. It may be obesity. It may be a high serum glucose. Physical activity is very important. High dietary salt is extremely important factor, and we'll talk about that from the point of view of patient's diet and from the point of view of patient's genetics that may predispose or not predispose patient for increased sensitivity to sodium chloride. Alcohol, told you that it's ambiguous, and definitely alcohol is toxic by itself. But from the point of view of relation to hypertension, it's depend upon patient's heredity. Fiber. Well, if patient will have a low level of nuts, of seeds, that will result in low level of raw fiber that may absorb cholesterol, absorb lipids, and that may result in predisposition to a lot of diseases. For instance, may result in predisposition to colorectal cancer, but indirectly to atherosclerosis and systemic hypertension, as well as other factors. Serum cholesterol, I already mentioned that. Vegetables, whole grains, and low level of fish, seafood. So therefore, so-called Mediterranean diet that will be, well, in contrary, rich in food, in fish food, seafood, rich in nuts, seeds, and fruits, will protect patient from development of atherosclerosis and atherosclerotic lesions like hypertension. Well, what you see here is well, mostly, so to say, normal adult aorta, because we can see here streaks associated to the presence of lipids. Well, here they are, those lipid uh, spots or lipid streaks. So that the early stage of atherosclerosis, but that stage of atherosclerosis will have no clinical manifestations, will be associated to very low risk if a patient will live well, longer, 20, 30 years after that. And that stage cannot be diagnosed by instrumental tests. Again, fatty streaks, here they are, indicating the earliest stage of atherosclerosis. And that will be not as mild. We can see some deformity of aorta, even in the case of mild degree, moderate degree presence of calcinosis, and ulceration with thrombosis with secondary risk associated to presence of embolism will be the marker of severe atherosclerotic lesions. Point is that if we are talking about carotid arteries in patients with ischemic heart disease, let's say, in that case, we need to pay attention to two basic, sections in arteries of greater circular circulation. That will be the aorta, mostly aortic arc, carotid arteries. That, by the way, may be used as a marker of atherosclerosis severity. Maybe heard about the thickness of intima media complex. That's nicely visualized by ECG, by ultrasound, and you can measure the portion of the blood vessel that first can be easily visualized, can be easily measured. Second, will directly represent the risk of atherosclerosis in general and hypertension precisely, specifically. Second region that will be of interest from the point of view of hypertension, we'll discuss later. That will be the renal arteries, not shown here. Renal arteries may be important from the point of view of risk of development of secondary hypertension, because decreased blood supply to kidneys may be the factor that will determine much less controllable hypertension that may be treated rather by surgery than by drugs. Later on, we'll discuss complications of systemic hypertension that may result in destruction of atherosclerotic plaques. One complication was shown about that is the ulceration and thrombosis. Another, basically, the other side of the same issue, when there will be destruction of the plaque, destruction of the artery, will be the dilation of elastic fibers of aorta or other arteries, and patient may develop aneurysm. First, aneurysm may be ruptured, and the high risk will be in the case of aneurysm that will be 6 to 7 centimeters and larger. Second, that will be again another source for development of thrombosis and development of embolic complications. From the point of view of diagnostics, we need to start definitely from symptoms. If your patient will complain of pain associated to location of the aneurysm, definitely for that, you and your patient need to know where the aneurysm is located. Therefore, if patient will be uninvestigated previously, that may result in sudden death because, well, patient may die within just minutes. Um, but a point is that if aneurysm is symptomatic, that requires attention not of a doctor, but specifically of a cardiovascular surgeon, and patient need to be immediately shifted to specialized hospital with ability to shunt the artery or will apply some other ways of at least palliative treatment for well, some short term. From the point of view of diagnostics, it may be done sometimes by plain ultrasound, but definitely the best way will be to contrast aorta to contrast its main branches. May be nicely done almost invasively by intravenous contrasting at CT of the chest, CT of the abdomen. And here you have about significant dilation of the aortic lumen and significant thickening of the aortic wall. Thickening means nothing by itself because it may be well quite soft atherogenic masses that may be easily destroyed. So if patient will have well, rapid growth of the aneurysm, if the size of the aneurysm will be increasing, and that will be associated to symptoms, that may be the most important marker or destruction of atherosclerotic plaque of the aneurysm. That's how the plaque will look like. The nice proof will be the cholesterol clefts, the needle-shaped crystals seen inside the wall of the artery, proving that that is cholesterol. And sometimes it may be fragmented, and atherosclerotic emboli may be found out in some distant regions. Well, that's again atheroma, typical shape of cholesterol clefts, and form cells with plenty of lipids inside, indicating ongoing process of recruitment of absorption of lipids. Well, that is the ulceration of atherosclerotic plaque that may result in development of aneurysm. That's how the embolus may look like. That is the artery, its lumen in the kidneys. That will be the glomeruli, tubules in the kidney, tubular interstitium, that is the artery. And inside of the artery, you can see some strange tissue. Well, that is abnormal with cholesterol cleft or two clefts inside that particle. That is embolus, the embolus resulting from the fragmented atherosclerotic plaque. Well, definitely the volume of the atheromes, if we talk about, well, for instance, ischemic heart disease, or well, thickness of the intima of the carotid artery will be directly related to hypertension, at least to systemic blood pressure. Well, what will be related to diastolic blood pressure is a different story because sometimes it may be also of atherosclerotic mechanism. Sometimes it may be associated to other factors. Sodium. Well, first of all, we need to say that if we talk about, well, the average, so to say, Western diet, again, no one knows what is the average Western diet, but well, something that the average people eat in large cities. That will be about, well, 5, sometimes up to 10 times more than our daily requirement in sodium chloride. So we eat many times more sodium that we need to eat. Definitely, that is associated to availability of sodium chloride. It's cheap and it's available everywhere. In contrast to what happened, for instance, let's say, well, several centuries ago, when salt was extremely expensive and it was extremely difficult to find it out unless you live just at the sea coast. And second point is that sodium chloride is associated to a lot of genetic mechanisms that may predispose patient to hypertension associated to over-ingestion of sodium. Well, first is definitely volume-dependent mechanism because sodium is electrolyte. If it will be dissolved in serum, in blood, it will be associated to retention of fluid, and therefore it may affect the autoregulation of fluid balance in the body. Second, that again is volume dependent, but will be associated to sorry. Will be associated to Retention of fluid will be the production of endogenous tubain-like steroids that are again sodium dependent. What will be the volume independent mechanism? It will be associated mostly to production of endogenous hormones or some vasopressive mediators like angiotensin. Therefore, there will be activation of angiotensin-mediated effects from central nervous system. It may be the direct stimulation by, again, sodium itself of smooth muscle cells in the vascular wall, and that will be the effect that will be go along with overactivation of sympathetic nervous system. It may be the hypertrophy of cardiac myoblasts and increased contractility of vascular smooth muscle cells. Talking about CNS effects, it may be overproduction of NF-kappa B mediator that may be released from central nervous system, from the heart itself. It may be mediators like AT1R. In renal tissue, again, it's vasopressive mediator, and the tumor growth factors beta production also will be associated to increased vasoconstriction. So point is that on one hand, we can have increased intake of sodium, so it may get into the blood vessels, including the blood vessels of kidney. But point is that there will be a lot of other factors that may be associated to over retention of sodium, may be genetic fault. A bit later, I'll show you what will be the mutations that will be associated to increase the absorption of sodium. But due to genetic factors, there may be more sodium that will be kept in patient serum. And then in other populations, it will not have those mutations. Or it may be, again, due to genetic reasons, decreased either number of nephrons in general or number of functioning nephrons. That may result in decreased excretion of sodium or increased reabsorption of sodium, and it may result in increased extracellular fluid volume and other factors that I just showed you. Another point is that, again, we need to pay attention to the function of central nervous system, other regulatory factors, that there may be overproduction of circulating substances that may result in retention of the sodium and uh, well, elevation of um, extracellular fluid volume, elevation of the tone of the blood vessels, or there may be decrease in production of some natriuretic substances, and there may be, again, impaired loss, impaired excretion of sodium. Well, this is well, brief, this short list of genes that may be associated to regulation of level of renin, elevation of regulation of aldosterone. Most of these genes are well, antihypertensive. So most of these genes will be associated to decreased production of renin, decreased production of aldosterone, or sometimes they may have ambiguous action. One may be decreased, another may be increased. Therefore, in most of the cases, the deletion mutation or some inactivation mutations may result in development of systemic hypertension. In most of the cases, the disease will be autosomic dominant, but there are some recessive mutations that will be manifested only if they will be homozygous. Well, that is the site of the action of those genes that they're marked by the star, by the asterisk. And they will be associated to the function of tubules. It may be different portions. It may be the Handler loop. It may be the distal portion. But the point is that in most of the cases, there are sodium transporters that will move sodium either back well, into urine or result in over retention of the sodium will be affected. So that will be, again, factor that may be associated to a patient's dietary habits, and therefore, even if patient will have mutation, but patient will take less sodium, a patient may be relatively safe from hypertension. There may be important feedback in regulation of renin release that may act both in primary hypertension and in secondary types of hypertension. Now, what will affect sodium retention will be the action of aldosterone, angiotensin 2, and those factors may be dependent upon the pressure in efferent arterial. There is macula densa over there. That will be the pressure sensitive zone. And therefore, if patient will develop some situations in which there will be decreased pressure in the efferent arterial, it may be some parenchymatous renal disease when there will be edema of the interstitium or sclerosing of the interstitium or the infiltration of glomeruli or block of basement membrane, or there may be a block in blood supply. That will result in over-release of renin, overactivation of angiotensin 1, overproduction of angiotensin 2, and mostly through aldosterone, there will be over-retention of sodium. Well, what we need to ask our patient in the case of presumed or verified hypertension. What will be the basic outline in approach for taking patient symptoms, taking patient's history? Well, definitely we need to find out what is the duration of hypertension. We need to find when the patient last measured the blood pressure and in which day or which time patient had less normal or less elevated blood pressure, what was the level of hypertension, if patient had long-standing hypertension. What is the cause of hypertension and how it's elevated, whether it's transient elevation or whether it's constant elevation. We need to find out what was the prior treatment of hypertension, the type of drugs, the doses, the side effects, and actually that's important because sometimes a very nice prescription will not be followed by a patient. Either there will be serious or very unpleasant side effects. We need to ask about some agents that may interfere to your treatment. It may be a different level of interference. It may be some drugs that may compete for antihypertensive medications in the liver. That may happen to some NSAIDs, non-steroid anti-inflammatory medications. Or on the contrary, presence of low dose of aspirin may protect patient from complications and may have beneficial action. We need to ask about intake of oral contraceptive medications because that will be important from the point of view of thrombotic complications. These drugs may damage endothelium, may predispose patient for some acute and sometimes very serious complications. Definitely, we need to ask because patient may not always be aware about drugs with the opposite action. Sympathomimetics may significantly increase the blood pressure. Patient may take them for other reasons like treatment of bronchial asthma or some urological indications. Steroids, we need to ask about excess in sodium intake, and definitely patient need to measure sodium intake. For that reason, we need to ask about alcohol. If patient will take more than 2 drinks per day, again, that may be the factor of hypertension. And sometimes herbal remedies. Sometimes they may decrease blood pressure. Sometimes, like for instance, if patient will take a lot of licorice, they may have some kind of aldosterone-like mechanism of action and may result in significant systolic and diastolic hypertension. Obviously, we need to ask about family history. What does it mean? It's up to you and your patient because family history is something that may be of polygenic mechanism. It may be predisposition to, for instance, just cardiovascular disease. and just associated to predisposition to atherosclerosis. It may be predisposition to pheochromocytoma, that's well known, to renal diseases, to diabetes, again with again direct link to severe atherosclerosis and cardiovascular issues, or to gout. Or at least we'll ask patient just about hypertension, because that will be by itself extremely important. Second part of today's lecture will be devoted to secondary causes of hypertension. Some manifestations of those will be muscle weakness, some attacks, spells of tachycardia, sweating, tremor. Some patients may notice thinning of the skin, or abdominal flank pain. In any case, no matter whether it's secondary or whether it's primary hypertension, we need to pay attention to what will happen to target organs. That is extremely important because that will be the marker of the stage of hypertension if it's primary. And in any case, in primary and secondary, it will be associated to patient's prognosis, to risk to patient's life. So ask about headaches, ask about attacks, episodes of transient weakness, blindness, loss of visual acuity, about chest pain, dyspnea, presence of edema, presence of claudication. Obviously, again, presuming that mostly we are dealing with a patient with atherosclerosis, we need to ask about at least atherosclerosis risk factors like smoking, like diabetes, like dyslipidemia, or physical inactivity. Concomitant diseases also will be important. Again, maybe other atherosclerotic diseases, or that may be associated to presence of systemic manifestations of, for instance, neuroendocrine tumors. Dietary history is important. If patient, for instance, will gain weight, that may be the provoking factors for systemic hypertension. We need to ask about, what type of food patient is taking, whether it's fresh. In that case, in most of the cases, it means that there will be low caloric load and low level of unsaturated, saturated fatty acids. If it's processed, in most of the cases, it will be rich of cholesterol and saturated fatty acids. Ask about sodium, ask about saturated fats. Sometimes sexual function may be the marker of severe atherosclerosis, at least in males, or some issues like aortic aneurysm, aneurysms of iliac arteries, or thrombosis. Features of sleep apnea is important because it may be associated to severe hypertension. Ask about morning headaches. Ask about daytime somnolence, so-called Pickwick syndrome, loud snoring at night, or erratic sleep. And what will be important, later on when we try to adjust patient's treatment, definitely we need to find out how patient is able to modify something that may be most simple and most effective, that is lifestyle and patient's compliance to prescribed drugs, prescribed treatment. You need to understand the nature of hypertension. We need to assess patients' ability to perform physical exercises. What about patients' food sources, financial constraints, ability to read and follow instructions, and need for some extra care providers. Well, from the point of view of progression, first of all, we need to say that the natural cause of disease will be relevant only for patients with essential hypertension. So natural history is only related to essential hypertension. Please remember that. That is a certain well-established disease. And we can say what will be some pre-stage background and how disease will progress up to complication forms and stages. That disease is more or less predictable. We know how it starts. We can understand how it will go. If we talk about secondary hypertension, there is no natural history for secondary hypertensions. Disease may be extremely severe right from the start, right from the initial complication, manifestation. Patient will have complications, and it cannot be never predicted. Therefore, only for primary hypertension we can say about stages of disease. For secondary, there will be no stages. Good. So first of all, there will be some degree of correlation of severity of hypertension to stage of disease and to patient's age. There may be, well, for instance, early hypertension that may be quite easily normalized if you modify a patient's lifestyle. Patient then may progress well further to established hypertension. It means that typically patient will be older with more significant, well, age-related or disease-related atherosclerosis. And at that stage, patient will have some organ lesions. Most important of those will be hypertrophy of the left ventricle. This stage again may stay uncomplicated or may progress further to complicated stage that may be just, well, accelerated course of disease. Or a patient may develop some cardiac complications. Most of them will be hypertrophy related, that is heart failure or myocardial infarction. There may be complications associated to state of large vessels like aneurysms or embolism. A patient may develop, well, sometimes lethal cerebral complications like ischemic stroke, thrombosis, or hemorrhagic stroke due to rupture of aneurysm. And quite often, patient may develop renal complications that may be the nephrosclerosis that may result in renal failure and the end-stage renal disease. Um, I told you that patient may develop systolic hypertension, or there may be combined systolic and diastolic complications. That may be the features of essential hypertension. So again, it's primary. It's primary. And primary complication may be either combined or it may be isolated systolic. First, typically, definitely, it's just a very rough, very primitive attempt to classify, but in most of the cases, combined when the patient will have both systolic and diastolic complication, it will be, well, relatively early onset. Isolated systolic will be directly associated to patient's age. Patient should be of at least 45 years old. Combined hypertension will require multiple mechanisms, while isolated systolic will be mostly associated to atherosclerosis and mostly stiffness of the arteries, peripheral arteries associated to distal atherosclerosis. Progression will be relatively slow and variable, which will depend upon those multiple factors, while it will be more rapid and more progressive, more, well, resistant to treatment in the case of isolated systolic. When we talk about consequences, definitely, well, combined hypertension will be associated mostly to coronary artery disease and nephrosclerosis, while the risk of stroke will be highest in patients with isolated systolic, and well, the patient may have congestive heart failure. What will work best in combined hypertension will be renin-angiotensin blockers, or, well, inhibitors of the enzyme or blockers of receptors, while for isolated systolic, we'll use diuretics and we use calcium channel blockers. Well, that is some, well, simple scheme that will try to represent what will be the mechanism of isolated systolic hypertension. It will be associated to reflection of the pulse wave, a reflection from those, well, small blood vessels with high resistance. So the systolic pulse wave will go away from the aorta, from aortic valve, will go to the periphery, and then it may reflect in different degree with different intensity from the high resistant blood vessels from the peripheral blood vessels, represented mostly the peripheral resistance. So that reflected pulse wave, in the case of severe sclerosis of those arteries, may interfere with systolic pulse wave from the next heartbeat, and that interference of reflected pulse wave from the previous beat may be overlaid on the next systolic pulse wave, resulting in significant elevation of systolic but not diastolic blood pressure. Well, please remember that we measure blood pressure indirectly. We use for that the Korotkoff method. We use the cough. I think we discussed that at the initial class that was devoted to the methods for the measurement of the blood pressure. So there will be no Korotkoff sounds in the case of pressure in the cough that will be above systolic blood pressure. There will be smooth blood flow beneath diastolic, and Korotkoff sounds will be heard with some different intensity in between systolic and diastolic. Definitely, it's not absolutely precise. So there is definitely some kind of errors in the case of trying to perceive the moment of onset of Korotkoff sounds, the moment of disappearance of Korotkoff sounds. They are not as intensive as somewhere in between. And therefore, that method is first subjective and will depend upon how nicely you can hear the beginning and the disappearance of Korotkoff sounds. Second point is that we use different devices with that are not quite precise, not quite reliable. Well, what was standard for many years, for many decades, was an aneroid tonometer that was based on the tension of the hairspring, and definitely, well, with time it would become more loose. And the older was that aneroid tonometer, the less precise it was. So the gold standard was and actually is the mercury manometer, but it's forbidden to use it in the clinic nowadays because of mercury. We cannot well bring mercury in the clinic because it may be broken, and we can cause severe intoxication for many of our patients. Well, electronic devices are also not quite precise. And actually, the best recommendation to use precise measurement is to calibrate, well, manual, the aneroid manometers or electronic devices. So there should be not more than plus minus 3 millimeters hydrogram difference in between the results of mercury device or aneroid or well, electronic measurement device. Well, again, some examples for mistakes are presented here. So first of all, for instance, you should never use a single measurement. Well, always while you communicate to a patient will move, patient will sit or stand before blood pressure measurement, and therefore always the initial measurement is higher, like for instance in the next case, next example, than the next or well, third measurement. Therefore, should never use only one reading. Well, all guidelines, American Heart Association, I cannot well remember these guidelines, recommend at least two individual measurements or better three measurements. Well, that example, again, that is erroneous because, they're rounded up to the nearest five number. That should not be, should round up to the nearest 2 millimeters in diagram. Same as is true for that measurement. Again, the rounding up to nearest 10 millimeters should not work. What should be done is, let's say, 82 or 142, 44, and so on. Uh, uh, well, um, then we need to to check whether well, measurement is correct, because if well, all three measurements will be same, you should doubt, because well, that should never happen. Always next measurement should be lower than the previous one. Well, and sometimes we cannot well properly visualize the auscultatory gap, so it may be well abnormality with diastolic pressure. That's also important. That is a classification of hypertension. The normal blood pressure in a patient is less under than 120 degrees, 20 millimeters hydrogram for systolic, less than 80 for diastolic. High normal is in the untreated patient up to 140, less than 140 or 90 for diastolic, and hypertension mild 140, 159 for systolic, for diastolic 90, 99. For moderate hypertension is 160, 79 for systolic, for diastolic 100 to 109. HV hypertension is over 180 for systolic, and for diastolic over 110. Definitely, ambulatory measurement of the blood pressure will be more precise, and typically will be associated to low level of blood pressure than a measurement of the blood pressure in the clinic. Therefore, sometimes you can predict the level of the blood pressure that will be in ambulatory monitoring by the clinical blood pressure, but actually the best way is to measure blood pressure directly by the pressure monitor. What should be done at physical examination? What do you need to look for? Definitely, first, you need to measure and measure properly the level of the patient's blood pressure. We need to assess the state of the target organs like heart, brain, kidneys, eyes, and peripheral arteries, and assess the presence of the atherosclerotic risk factors. Specifically, we need to assess presence and degree of left ventricular hypertrophy. For instance, at inspection, we can assess the position of the apex beat, whether it's exaggerated, whether it's shifted well leftwards, downwards. We can assess the apex beat by palpation, trying to find out whether it's increased in amplitude, whether it's increased in stiffness. Again, whether it's shifted well down and leftward. We need to assess the width of the apex beat by palpation. And the left ventricular hypertrophy definitely will be assessed by percussion of the heart. The left border of relative heart dullness will move leftwards. Signs of heart failure, well, congestion, less circulation most often. Presence of myocardial infarction, the past history, stroke, well, whether it's ischemic or hemorrhagic, renal failure, presence of albuminuria, presence of systemic signs of atherosclerosis or aortic dissection. I think we'll skip that slide. Blood pressure monitoring, that's extremely important. First of all, because in that case, patient live more or less normal life. It's not well the artificial clinical situation. Patient will do what patient typically is doing in routine practice. You can assess daytime blood pressure. You can assess nighttime blood pressure. You can assess a result to physical load, to emotional stress. You can assess the efficacy of medications. Definitely, please remember that I told you that you can measure blood pressure in different portions of patient's body. You can assess the blood pressure, for instance, in the forearm, the patient's ankles, but better use proper sleeves, proper cuffs to measure blood pressure in the normal location at the arm. So patient should keep a diary. It should look like that. So patient need to indicate at what time patient was doing what. Especially, it's important to mark intake of medications. Definitely, there'll be a direct relation of the risk of some complications, cardiovascular events, to type of hypertension. So it will be absolutely different in the case of clinical hypertension to the same degree of elevation of the blood pressure, for instance. It will be different in the case of daytime hypertension to the same degree of blood pressure. It will be even high in average 24-hour blood pressure level. And the highest will be if we talk about specifically of nighttime hypertension. If a patient will have hypertension during sleep, that will be associated to highest risk of complications and death. So that's how you should analyze the chart of blood pressure measurement. Typically, the recording will start and will be terminated at the same time. So we use literally 24-hour monitoring. We need to assess the average level of the blood pressure. And in that case, for instance, you can conclude that patient is having grade 1 hypertension. You can correlate that to a clinical blood pressure measurement. You can assess the systolic blood pressure, and according to systolic blood pressure, the hypertension will be related to the higher grade. According to diastolic blood pressure, the grade of the hypertension will be not as high. Another point, what is important, is so-called nighttime dipping of the blood pressure. You need to assess how significant is decrease of the blood pressure, systolic, diastolic, at the nighttime. And a nighttime systolic blood pressure or diastolic blood pressure dipping will represent the degree of the risk to patient's health. Very important from the point of view of assessment of the blood vessels will be to assess the state of the retina. According to retinal blood vessels, we assess the stages of retinal hypertensive retinopathy. That is so-called Keith-Wegener classification. And that will be important again from the point of view of staging of essential hypertension itself, and from the point of view of predicting complications. First stage means that there will be just more narrow arteries and slightly increased tuberosity of arterial blood vessels. There will be mild degree of arteriosclerosis. The increased light reflex means that arteries are slightly sclerosed, and the next stage, but within same first stage according to the classification, will be silver wiring. Light reflex that will be increased typically will be called copper wiring. It means that artery is slightly transparent and it's bright with some reflexes, but it's of more or less red color. Silver wiring means that artery is not transparent. So that is the next stage from the point of view of atherosclerosis progression. Arteriovenous snipping. For that, you need to find out the site in the retina when artery will cross the vein and see what will happen to the vein. Cotton wool sign is presence of the exudates, means that the blood left the artery, and after that you see that the clots of the fibrin, clots of proteins, clots of destroyed RBCs, they are whitish, and that's why they are called cotton wool. Flame and blood hemorrhages is fresh hemorrhages. It's frank blood visible at the retina in the vitreous body. Sometimes it may be subretinal hemorrhages, and the highest degree of hypertensive changes and highest risk for patient's life will be associated to papillary edema. Papillary edema is a very important point because on one hand, papillary edema means the highest degree of progression, the climax of possible changes, what may happen to patient's retina. First. Second, papillary edema means the acute risk to patient's life. It means that right now, patients is having the risk of edema of patient's brain and then may die of that. And third, papillary edema in a patient with initial hypertension, with initially diagnosed patient is having almost no history of hypertension. And that could mean presence of secondary hypertension, indicating presence of some intracranial hypertension as a possible cause of secondary hypertension. Well, that is the summation of some of those changes. Arteries may be well narrowed, more thin. Very important so-called salus or salus signs is arteriovenous nipping. You need to pay attention what's happened to the vein after being crossed by the artery. If almost nothing, just it became narrow at the site of crossing, that is salus 1. If it will become narrow, well, after being crossed by the artery, well, here, that location, it means salus 2. And if it will just disappear after being crossed and initial, well, portion of the vein will become dilated, that is salus 3. That's how you may measure the blood pressure in the artery by assessment of what will happen to the vein. Then there may be some microinfarcts that may be signs of dystrophy of the retina, exudation into vitreous body, hemorrhages like flame, and there may be signs of papilla edema. Well, that is cellus 1 and 2 signs. On one hand, there is narrowing like, well, mm, the conical narrowing nearby the crossing of the artery to the vein. That should be called cellus 1. If not, well, narrowing of the vein, well, proximally, and distal dilation of the vein. So in that case, it will be called cellus 2, grade 2 cellus. And beside that, there is copper wire sign because artery is still transparent. It's more or less reddish, but it's more bright given the light reflex. That will be the flame-like hemorrhages that the arteries and the optical fundus are ruptured. Again, copper wire sign. The retina is blued due to exudation, due to edema, and presence of intravitreal hemorrhages. Signs of dystrophy of the retina, here they are. New scotomas, blind spots in the optical fundus called scotomas. That is not scotoma. Good. And again, cotton wounds will sign like the star. There is some kind of blurring and a whitish retina nearby optical disc. Cardiac complication. First of all, again, please remember that that will be the marker of the second stage of essential hypertension, but only for essential hypertension. Definitely, patient may develop hypertension having secondary hypertension, but it will not be the mark of the stage of disease. For essential, it means that patients having stable hypertension, that is second stage. A patient may develop changes due to endothelial dysfunction, due to increased left ventricular wall stress, some kind of exaggerated atherogenic or renin angiotensin activation system. So I told you that we can diagnose hypertrophy by the physical methods. It may be done nicely by the X-ray. You can see so-called boot-shaped heart, cœur or sabot in French. And please remember that dilation of the left ventricle may be associated to heart failure already. In that case, it means that patients having third stage of essential hypertension that may be differentiated nicely by, again, clinical symptoms, presence or absence of congestion in the lesser circle of circulation. First. Second, by the ecocg by assessing the end diastolic volume of the left ventricle and by the pressure in the left ventricle and in the aorta. Dilation and the dystrophy of the left ventricle may be associated to arrhythmias and to increased sudden heart death. Definitely, presence of hypertrophy will be associated to increased risk of coronary ischemia, especially if patient will have concurrent coronary heart disease. Presence of left ventricular hypertrophy will increase demand in blood supply, will exaggerate the symptoms and signs of myocardial ischemia. That is left ventricular hypertrophy. Typically, it's concentric. It will be associated to the mechanism that will maintain elevated systolic blood pressure, but later on, patient will have dilation of the left ventricle, and that will be the marker of rapid development of heart failure. How can we diagnose left ventricular hypertrophy? Obviously, by changes in, first of all, standard and chest leads. If we talk about standard leads, there will be increased voltage of the R in first standard lead and increased voltage of wave S in third standard lead. There may be some signs of overload of the left ventricle, depression of ST segment in the first standard lead. T wave may be diphasic, biphasic, and inverted in first standard lead, sometimes in second standard lead. In unipolar limb leads, again, there may be depression of ST segment in, first of all, AVL, sometimes in AVF. Flat or inverted T wave may be seen in AVL, in AVF. For precordial leads, there will be increased amplitude of R wave in left chest leads and increased amplitude of S in right chest leads. So sum of R in V5 and S in V1 will be more than 35 millimeters. Tallest R wave plus deepest S will be more than 45 millimeters. A nice, very simple to visualize sign will be that electrical axis of the heart will be shifted. If normally the tallest R wave will be in fourth chest lead, in a patient with left ventricular hypertrophy, tallest R wave will be in fifth or sixth chest lead, and that will be more than 26 millimeters. Definitely depression of ST segment in left chest leads associated to inverted or biphasic T wave. Sometimes there may be signs of a left bundle branch block because of hypertrophy, because activation of the thicker heart muscle requires more time. Well, in that case, there is a left ventricular pattern. You can see a very tall R wave in six chest lead, and then deepening of the S in the first chest lead, and depression with the inverted T wave in left chest leads. Again, that is a sign of left ventricular hypertrophy. R wave in V5, in V6 is taller than that in V4, and taller than 26 millimeters. Deep S in right chest leads. Same here, while deepening of S wave in right chest leads, and there's domination of R in V5 in this case. It's dominating over V6, but it's also dominating over V4. That's important, indicating that there is left ventricular hypertrophy. Same here. While obvious signs of overload, significant depression of ST, negative T, and tall R wave in left chest leads, deep S in right chest leads. That is, as far as I see, horizontal, associated to horizontal axis of the heart. Okay, systemic hypertension. In that case, no inversion of T wave, but there is, in the patient, just mild increase in amplitude of R in left chest leads. Well, we don't have much time left, and we need to discuss systemic hypertension. So very briefly, We need to say that definitely, well, in a patient with systemic hypertension, there will be a lot of pathways that will result in complications such as left ventricular failure, arrhythmias, and ischemia of the left ventricular myocardium. That will be the apoptosis of cardiomyocytes, hypertrophy itself, and that will be associated to altered calcium metabolism, that will be associated to altered relaxation and increase in demand in blood supply. Myocardial fibrosis will result in increased stiffness of left ventricle and may result in impaired diastolic filling. That will be the straight way for the left ventricular failure. Myocardial fibrosis may result in altered conduction, and issues in microcirculation may result in impaired coronary flow and development or progression of ischemia. So hypertension, due to different mechanisms such as left ventricular remodeling, the hypertrophy, diastolic dysfunction, vasoconstriction, may result in development of congestive heart failure. And then it may be the source for development of atrial or ventricular arrhythmias, fibrillation. A patient may develop stroke and coronary heart disease. From the point of view of state of kidneys, there may be nephrosclerosis that may result in elevation of serum creatinine. A patient may develop hypertensive kidney that will be on one hand factor of progression of hypertension itself, because there will be decrease in blood supply to central artery in the glomerulus. There will be hyalinization of the arteries that may in turn increase blood pressure even higher, even more. Second, hyalinization of the arteries inside glomeruli will be the way for impaired renal function, for elevation of creatinine level and azotemia. Sometimes we need to pay attention to signs of systemic atherosclerosis. That will be the bruits over aorta, over renal arteries, or sometimes over iliac and femoral arteries. Acute complications such as hypertensive crisis may develop in a patient, so that is another important and dangerous complications. One of the markers of that will be the development of advanced retinopathy. So patient will complain of severe headache, visual disturbances. Sometimes patient may have gastrointestinal symptoms that are mostly related to increased intracranial blood pressure, intracranial pressure. That will be the nausea and or vomiting. Some patients may have weight loss in the case of recurrent attacks of hypertension. A patient may develop dyspnea, this is a mark of the heart failure. Maybe some degree of encephalopathy. In that case, typically patient will already have signs of left ventricular hypertrophy. And what is important is development of severe renal impairment. Patient's creatinine level will be higher than 300 millimoles per liter. Sometimes, in the case of mild, it will be from 115 to 300. And in some of the cases, there will be macroangiopathic hemolytic anemia due to impaired production of erythropoietin in kidneys. Now we need to shift to causes of secondary hypertension. We need to subdivide that to diastolic and systolic. For diastolic hypertension, we have plenty of renal causes. I will not discuss all of them, but they will be subclassified in turn to parenchymal, when there will be affection of the renal tissue itself, in the case of affection of glomeruli, affection of tubules endointestitium. There may be some inborn causes. Patient may develop accumulation of amyloid in kidneys, and so on. Or there may be occlusive vascular disease. It means that more or less large renal arteries will be affected by atherosclerosis, by some inborn lesions like fibromuscular hyperplasia And there are again a lot of sub-causes, sub-forms of fibromuscular hyperplasia. Maybe thrombotic affection or embolus, or some other diseases like hyperplasia of kidney, or nephroptosis, for instance, when kidney will just well move down, and that will result in bending of renal artery and some block of that. Coarctation of aorta may be another mechanism of decreased blood supply to kidneys, and in turn that will activate renin-angiotensin mechanism of hypertension. A lot of causes will be associated to brain. What you need to pay attention to is increased intracranial pressure, the basic marker of most of those causes. If patient have brain tumor, if patient have encephalitis, gangrioneuroma, some other diseases, in most of those cases, patient will have increased intracranial pressure, and that will result in edema of the optical nerve. That was talking about when we were discussing assessment of the retina in a patient with hypertension. If you suspect neurogenic hypertension, the easiest thing that you need to do is assess ocular fundus and check for presence of edema of the optical disc. Adrenal causes, patient may develop pheochromocytoma, over-release or production of catecholamines. It may be over-release of aldosterone, primary aldosteronism, due to, again, adrenal tumor. A patient may develop Cushing's syndrome or production of steroids. Again, it may be primary or secondarily, or it may be a adrenal genital syndrome or production, again, of steroid hormones that will be in turn associated to fertility of the patient. Elevation of blood pressure may be associated to toxicosis, toxemia of pregnancy, pre or eclampsia. And there may be other causes like hyperfunction of thyroid glands. Patient typically will have a high level of calcium. Intake of contraceptive pills may result in both atherosclerotic lesions and directly in predisposition to spasm of coronary arteries. Licorice injection, it will be well, plenty of, for instance, let's say antitussive pills if patient will have a chronic cough, and they will take plenty of licorice, may result in something that will simulate high level of aldosterone. Amphetamines, some narcotic drugs, and then the other medications may result in hypertension. For systolic hypertension, it may be increased stroke volume of the left ventricle. Like that may be seen in aortic regurgitation, so-called hemodynamic hypertension. Similar mechanism may be seen in patients with patent ductus arteriosus. Sometimes it may happen in complete heart block, but it's rare event. Similar mechanism with the overfunction of the heart, overstimulation of the heart, when we see in thyrotoxicosis, and in some other diseases like compensatory hypertension in anemia, or increased level of calcium in Paget's disease. And decreased distensibility of aorta when it will be too stiff to tolerate fluctuations of the blood pressure may be seen in severe atherosclerosis or coarctation of aorta. That is actually a different classification of, again, same secondary mechanisms, classification that will be used in clinical practice, so we don't well follow that. Again, we can subdivide mechanisms to renal, parenchymal or arterial mechanisms, endocrine, causes associated to some defects of enzymes. That will be the atherosclerotic lesions of the artery, very small lumen narrowing of the artery. And definitely, significantly less blood will be delivered to macula densa, the juxtaglomerular complex, and in that case, there will be activation of renin angiotensin mechanism in the patient. So, if you see lesion like that, that may be on one hand the mechanism for development of secondary renal renovascular hypertension or renal arterial hypertension. Second, it may be nicely treated by stenting of the artery. And in contrast to primary hypertension, patient will be cured. Well, that is another feature of secondary hypertension, so that if we have natural cause, natural progression of disease in the primary, and disease can only progress. Secondary hypertension may be cured once and forever if you'll be able to remove the cause for that hypertension. That is the aneurysm of aorta. You can see the second lumen that will develop in the renal artery in that case. Unfortunately, that will be the not not enough for compensation of the decreased normal lumen of the blood vessel, and therefore, no matter that it may look like dilation of the renal artery, it will be associated to decreased blood supply to the kidney, and again activation of angiotensin mechanism of hypertension. That is fibroplasia of the renal artery. That's how the artery may look like macroscopically, and it will be again visualized sometimes by CT, sometimes by direct contrast when you insert the catheter into the aorta and directly inject the contrast into the kidney. So that will be again treated by surgery. In most of the cases, there will be intimal hyperplasia, as in that case, that is the intima, that thick. But hyperplasia may be in any section. It may be the elastic portion that will be hyperplaced, or it may be subadventitial portion of the renal artery. Cushing syndrome, that is increased mineralocorticoid action. A patient will develop osteoporosis in that case. There will be high level of calcium. Buffalo hump, another very important marker. Patient may develop striae, typically red, apron-like pendulous abdomen. Patient will have moon face, red cheeks, easy breathability. What is important that patient will have changes in electrolytes, and there will be low level of potassium and tendency for alkalosis. It's buffalo hump. In the case of primary aldosteronism, there'll be again indirect activation of renin-angiotensin system. So aldosterone will act by itself on the tubules and indirectly through renin-angiotensin system. Hyperaldosteronism may act through increased sodium reabsorption, hyponatremia, increasing plasma volume, and directly inducing hypertension. So that will be associated to renin-angiotensin mechanism, but sometimes in the case of over accumulation of plasma, there may be compensatory decrease in renin-angiotensin mechanism. So that may be the mechanism that is not directly involved, and therefore in some patients may be overactivated. In some, in response to increased plasma volume, it may be suppressed. Please remember about hypokalemia. Patient may have some clinical signs of that, maybe general weakness or muscle weakness, paralysis. Patients sometimes may have metabolic alkalosis, and polyuria is another manifestation of increased potassium excretion. Pheochrocidoma may be manifested by hypertension that will come and go as attacks. Typically, it's paroxysmal. Quite rarely, it will be persistent. What is important will be severe variability of the blood pressure. Patient may develop orthostatic hypotension. Paroxysm of hypertension may be provoked by stress. It may be provoked by some pharmaceuticals like histamine, nicotine, caffeine, by beta blockers. It may be the result of intake of glucocorticoids or tricyclics. And what you may do yourself to provoke the attack of hypertension and to prove the presence of disease is abdominal palpation. Urination is not consistent sign. So typically, if you'll palpate kidneys, you'll squeeze adrenals, and that may provoke attack of hypertension if patient is having pheochromocytoma. Which symptoms may be associated, which symptoms may develop during the attack of hypertension will be the severe headache, sweating, palpitations, severe nervousness, anxiety. A patient may have chest pain, arrhythmia is very common, and patient may develop pallor. Neurofibromatosis is another disease that may be associated to pheochromocytoma. So in patients with neurofibromatosis, please screen for pheochromocytomas. Hypertension may be drug-induced, so it may be well secondary to exogenous corticosteroids. It may be the result of treatment of thyroid hyperfunction, and if patient will take excess of thyroxine, that will result in hypertension. Like risk already mentioned, oral contraceptives and some narcotics. Very important will be to exclude brain tumors because sometimes may save patient's life if you diagnose that in time, and the patient will be prone for treatment. That may save patient, otherwise patient will die. Good. What will be the features suggestive for secondary hypertension? Is onset of hypertension in a young patient at the age of less than 45 years old or after the age 55. If hypertension is severe, if it's of sudden persistent onset, if it's a refractory hypertension, if there will be a poor response to previous therapy, if there will be paroxysmal attacks of hypertension with palpitation, tremor, perspiration, if there will be multiple involved multiple systems, sometimes asymmetry of pulses, asymmetry of blood pressure at left and right side, at upper and lower extremities, presence of abdominal broods, some masses that may be endocrine tumors, and presence of end organ damage definitely may be seen in primary hypertension as well, but will develop earlier and will be more severe in patients with secondary hypertension. And laboratory abnormalities will be also important to pay attention to. Good. Well, that is aortic coarctation seen here by the arrow as one of the mechanism of severe hypertension. Just another example. Good. Okay, that is all for hypertension. If you have questions, please ask me. If not, I will have the last topic on Saturday. It will be devoted to heart failure. We will try to summarize some issues that we discussed when we're talking about valvular heart diseases, but there are a lot of things to discuss beside that when you talk about primary myocardial diseases like cardiomyopathies, like myocarditis. And please think whether you wish or not to arrange extra classes, extra seminars. If yes, be ready to participate actively in those classes. Good, please text me if you have any ideas, well, here in chat or well in the Google class. If not, then it's all for today. Good luck and goodbye. See you well next time on Saturday. Goodbye.